Good morning. I want to welcome all the new third-year clerks to their first week of their psychiatry rotation, their first Friday, and therefore their first Seinfeld. Today's discussion will be on the episode, The Non-Fat Yogurt. I also would invite any of our interns to unmute as well and let me know from their perspective what particular scene, what particular character struck you as interesting, and therefore begin our discussion on the non-fat yogurt. Anyone?
I can start us off. I think George's manifested arm movement was particularly interesting. And he was even called out by the doctor later in the episode that, this was something he was producing for an external reward and not a real illness. So I was thinking that's like a fictitious form of movement. Yeah. Again, I think he thought it was a benign thing, but then keeping that up the entire episode definitely played into it even more.
Yep. So for George Costanza in this episode, he is presenting with a physical sign that has no basis in physiology after extensive workup and evaluation. When that happens, usually psychiatry is consulted. And one of the first things we have to understand, and I think for our purposes, a couple of medical terms that we need to review include those of psychosomatic and psychogenic. And this is, I think, especially important for an inpatient consult team. When George Costanza presents, well, I'm saying inpatient, but of course, George actually presents to ambulatory care. Nonetheless, when George Costanza presents with the chief complaint that he does, even before the physician asks the first question, they can be reassured that George is struggling with a psychosomatic illness. And that's because every illness that, and I should say every or any illness that is likely afflicting George has both psychological and somatic components to it. That's the same exact thing as saying that contributing factors to George Costanza's illness include those that are biopsychosocial. The biological factors certainly would be the somatic component, and the psychosocial would be the quote unquote psycho component of the psychosomatic illness. So it says one in the same. And there isn't a single illness, there isn't a single situation that a medical student, resident, or attending would be in where that is not true. So within a second, we can all agree that George's illness is in fact psychosomatic, fully understanding and appreciating the definition of that clinical term. For every mental disorder that is described in the DSM, with the exception of delirium, which is not a mental disorder, the clinician must always investigate whether the cause is due to the direct physiologic effects of a substance or medical condition. That is, they have to investigate an organic etiology for an individual's behavior. When no underlying etiology with regard to basic physiology is discovered pertaining to someone's physical complaint, the term that we often use is psychogenic, right? So the idea here is part of regression, and that is if you start out with the belief that what George is struggling with is psychosomatic, when you remove the somatic component as meaningful or important in the origin or perpetuation of the ailment, the only thing you're left with is the psychological, right? So psychogenic. Along those lines, we formulate treatment planning in which psychological factors are deemed to be central, right? So psychogenic. So at this point, since we have proof in the very script of this episode that there is nothing physically wrong with George. His illness, whatever it might be, must be psychogenic. That is, psychological factors must be deemed central in the etiology and/or perpetuation of his chief complaint. The next point in the algorithm is whether or not George Costanza is lying. Because if he's lying, there are two illnesses we have to discuss. But if he is not, there are two other illnesses that are in our differential diagnosis. So if you're drawing this out as a flow chart, the point we're at in our evaluation is whether or not George Costanza is misrepresenting his symptoms. I think that's the politically correct way that it's described in the DSM. The bottom line is, have we caught this individual in a lie? Now, I think in this particular episode, it's rather straightforward. I think everybody could appreciate that in real life, this is a very, very difficult part of the treatment tree. That is the decision-making tree, right? So let's briefly pause. Let me put it back to the group. Up to this point, what questions do we have?
I'm wondering, oh God, I'm wondering if George felt that way when that guy, I forget his name, the one who works with if he felt inferior or something, and that's what caused his symptom.
His name is Lloyd, and I think you're onto something here, because we also know in another episode in which Lloyd presents, George's parents actually non-verbally and at some point even verbally tell George that Lloyd is the son that they never had. So there's significant emotion with regard to George Costanza and how he feels towards Lloyd Broad. I don't think there's any doubt about that. Now, again, I think you have to cheat. You have to actually know those other episodes, because I think he's in he's in two more. But having said that, there's a parallel here in that when we investigate a patient's chief complaint, we do talk to other collateral informants. We talk to the family. We talk to other prescribers. So watching additional episodes prior to and perhaps even after the non-fat yogurt is parallel to taking a full history, including that from collateral individuals. So easy parallel. Again, we've reviewed the first three steps in this decision-making tree. Step one, acknowledge that the individual's condition is psychosomatic. That's easy because we can say that for every single patient you will ever see in your medical career, irrespective of your future vocation. Psychiatrist, neurologist, internist, doesn't matter. Number two is understand the term psychogenic. That's when that psychosomatic illness has revealed nothing when it comes to the somatic component. And by default, the clinician understands that psychological factors are deemed to be central in the individual's or the individual conditions, etiology and/or perpetuation. And then finally, C, is the individual misrepresenting their symptoms? Are they lying? Again, with regard to the first three steps, any questions at all? Not necessarily pertaining to the non-fat yogurt, just in general, as we work through what ails George Costanza. All right, let's say that there is no discrete evidence that George Costanza is lying. Now, I know the consensus would disagree. We want to rewrite the script for teaching purposes. So let's look at the script and let's consult with Larry David, and let's all agree that the evidence in that script is going to be deleted. And now we are left with no discrete evidence that George Costanza is lying pertaining to his quote unquote involuntary movement. If that is the case, we are in that column in our decision tree that he is not lying. Stated differently, if there is no discrete evidence that he is, the patient is never lying, right? That's the default. That is unconditional positive regard. And that's irrespective of what your gut tells you. It's irrespective of what you quote unquote really think is going on. You must operate from the stance that the patient isn't lying until there is discrete evidence that they are. And if we are going to take the part of that script in the non-fat yogurt that reveals that George Costanza is lying in this situation and delete it, we are in that column where he is not lying. That is always going to be the default. And when we're here, there are two conditions that are in our differential diagnosis. Anybody understand, name, and can tell me what those two mental disorders are? One is called somatic symptom disorder, and the other one is called conversion disorder. In both conditions, the individual is presenting with a chief complaint for which no underlying physical etiology can be found. Therefore, psychological factors are deemed to be central. And the patient, or I should say, there is no evidence that the patient is providing misinformation. I want you to think of somatic symptom disorder as a multi-system disease. And if within that, the individual is only presenting with deficits in voluntary motor and or sensory function, it's a subset of somatic symptom disorder called conversion disorder. And the prevalence of conversion disorder is such that the American Psychiatric Association has pulled it out from the general idea of somatic symptom disorder and has created its own, and has allowed it to create its own illness. Right. So again, somatic symptom disorder is a multi-system illness within which an individual may have neurological signs. However, if those neurological signs, specifically deficits in voluntary motor and or sensory function, are the only presenting signs, then we will not call it somatic symptom disorder, although you would be correct. The single best answer would be that subset of somatic symptom disorder called conversion disorder. Now, there are two other illnesses that I want to add into this differential diagnosis. But before I go there, any questions about somatic symptom disorder or conversion disorder? All right, two other illnesses are published in this same chapter. One is called illness anxiety disorder, and the other one is referred to as psychological factors affecting medical conditions. They should be in your differential, they should be in the conversation. However, if for today's purposes, we reach the objective of understanding somatic symptom as well as conversion disorder, I think we will have reached this morning's objectives, whether or not these other two come into the conversation. But I did want to mention the other two. Illness anxiety disorder, formerly known as hypochondriasis, is a preoccupation syndrome. And it's a preoccupation syndrome that is similar to body dysmorphic disorder. Now, in 2013, with the publication of the DSM-5, the American Psychiatric Association removed body dysmorphic disorder and placed it in a new chapter in the DSM called the obsessive compulsive and related disorders. Body dysmorphic disorder is a condition in which an individual has a preoccupation with an imagined defect in appearance. And with that preoccupation, you could understand why it would be in the OCD spectrum. Now, for whatever reason, the American Psychiatric Association looked at illness anxiety disorder, recognizing that it too was a preoccupation syndrome, not with an imagined defect in appearance, but with having or acquiring a significant illness. And while that seems to be an easy fit in this new chapter titled The Obsessive Compulsive and Related Disorders, the American Psychiatric Association decided to keep illness anxiety disorder in the current chapter, along with somatic symptom disorder and conversion disorder, which makes little sense. So I think and it's never too early to start preparing for your shelf exam. For purposes of exam study, feel free to take illness anxiety disorder, a preoccupation syndrome, and have it piggyback body dysmorphic disorder, the other preoccupation syndrome, and study it within the context of the obsessive compulsive and related disorders, right? So think of OCD, think of body dysmorphic disorder, and think of the condition formerly known as hypochondriasis, illness anxiety disorder, along a continuum. The other condition in this chapter, that is psychological factors affecting medical conditions, may or may not truly belong in this chapter. My take is that it does, but then again, it's best to conceptualize that it doesn't. And let me explain briefly what I mean. Psychological factors affecting medical conditions include those very psychological factors, alcohol use disorder, that affect known medical conditions, cirrhosis, psychological factor smoking, medical condition lung cancer, psychological factors denial, medical conditions, etc. Right? So along that line, this makes like a ton of sense. But then again, it should not be necessarily compartmentalized into a single chapter. This idea of psychological factors affecting medical conditions really should span every single factor of the DSM. Like, for example, in the chapter of schizophrenia and other psychotic disorders, we know that between 80 and 90% of individuals with schizophrenia smoke. We also know that individuals with the condition schizophrenia have a lifespan of about 52 to 54 years of age, which is significantly reduced compared to the general population. And we also know that the number one cause of mortality in this population happens to be smoking or cigarette-related illness. It's not suicide. Right? So for someone treating an individual with schizophrenia, or in a clinic that treats 50 to 100 individuals with schizophrenia and even schizoaffective disorder, not to think of psychological factors affecting medical conditions would be borderline negligence, right? So this condition of psychological factors affecting medical conditions really does span every single chapter of the DSM. The APA decided to stick it in this one chapter. However, I do see it removed, and I see it less of an illness and more of a qualifier of every illness. Right? So when you think about those two illnesses, those two latter illnesses, in that respect, the true differential here for George Costanza, bringing this back to the non-fat yogurt, is that we're dealing with either somatic symptom disorder or conversion disorder, and we can leave it simply as a two-tier differential. However, when you take a closer look at this script, it is revealed that George Costanza is in fact lying. So now our differential even broadens to include two additional conditions. Before we get there, I want to again pause and ask the group if they have any questions at this point. All right, we're good. Well, if we caught George Costanza in a lie, and it appears in fact that he is definitely lying, now we have two conditions that are on the table called factitious disorder and malingering. Now, again, factitious disorder, fairly straightforward. We're going to talk about this in a second. Malingering is a clinical condition. However, it is no longer deemed a mental illness. So the M word still comes up in exams, and it's definitely still discussed in academic circles and clinical circles. But with regard to actual progress notes, there is no designation, not since 2013, of malingering. and because of that, let's just tackle this condition first. To decide or differentiate whether George Costanza has fictitious versus malingering, the question the clinician has to address is what George's motivation is. In psychology and psychiatry, motivation goes by the clinical term gain. So gain, motivation are interchangeable terms. If George's gain is external, if there is an external incentive that is discovered, then he is malingering. And that's what looks like is guiding George's behavior. And that's in the script. So the non-fat yogurt does appear to be a fictional case of malingering in George Costanza. In this case, that particular condition is not codable. We would not document the M word in the medical record. And there's other designations for it that I think are beyond the scope of this particular conversation. But for all intents and purposes, and that includes the shelf exam, malingering would be the single best diagnosis. In the real world, how we actually document it would be a little different. Again, beyond the scope of what we're discussing this morning. If an external incentive is not discovered, the default is that the motivation or gain is therefore internal. So there's something that is subconscious that is guiding the individual's behavior. Again, if you don't know, and it might just be because you just met the person and you haven't had time to search for any potential external incentive. In such a situation, again, it doesn't matter what your gut tells you. It doesn't matter what you suspect. If there is the absence of an external gain, the default is that it must be internal. So it's always internal until it's not. And the condition in which somebody is consciously manipulating their symptoms, when they're making a conscious effort to deceive for unconscious reasons, right? Unconscious gain. That condition is called factitious disorder. And factitious disorder carries the worst prognosis of any condition that we discussed this morning. And I think once you really appreciate the complexity of how someone can lie to your face for reasons that they are unaware of, you can quickly recognize and appreciate why this carries the poorest prognosis. Matter of fact, the prognosis is among the poorest of any mental condition, any mental disorder. Very complex etiology. Factitious disorder can be imposed on oneself, or it could be imposed by another, formerly known as by proxy. So the condition was formerly known as Munchausen's by proxy. So Munchausen's by proxy evolved to factitious by proxy, which has now since evolved to factitious imposed on another. Questions? For the CL psychiatrist or any medical student rotating on a CL service, we have to recognize that anytime we get consulted on a patient for purposes of rule out conversion, quote unquote, if looking into the medical record, there are any tests that are pending, we have to reserve judgment because we only would determine the individual to have a psychogenic illness when that extensive medical and or neurological workup has been concluded and has been negative. Now, we wouldn't necessarily defer seeing the patient, but certainly in our progress note, in our dictation, we would simply say that right now, our findings are inconclusive and that we will need to review the pending lab results, the pending tests to provide a provisional diagnosis. We only have 5 minutes left. Any other character, then George took a little while today. Any other character you identified in the non-fat yogurt you'd like to briefly discuss with the time remaining? All right, if there's no other characters, we'll end it here. I believe the team will be together this morning. I will be there in about 30 minutes. We'll connect then. Otherwise, we'll see everybody back, not only over Graphic Medicine, but again at 12:30 today. Thanks.